Hello and welcome to this talk from the Museum of Human Diseases at St George's University of London. I'm Carol Shields and I'm the museum curator. In this series of podcasts, I'm going to be sharing some of the stories from the museums and archives with you. The first story is about a 59-year-old man who visited his doctor in 1826. That's almost 200 years ago. He had symptoms of indigestion and abdominal pain. On examination, he was found to have an abdominal mass around the size of a large orange. He had a weak, rapid pulse of 110, and he was extremely pale. The patient's high heart rate, coupled with his paleness, indicates that he was probably anemic. At this time, there were no tests available, such as would be offered by the NHS today. And based on the examination and the facts described, the doctor concluded that the disease was of a malignant nature, but he was unsure what organ it affected. In consultation with Benjamin Brodie, a leading surgeon at St George's, the diagnosis was agreed to be fungus hematodes. This is an archaic medical term, and in this 1809 publication by the surgeon James Wardrop, it is described as a soft hemorrhaging cancer that is invariably fatal. Wardrop was a well-known and skillful surgeon, and he writes both logically and eloquently on this subject. He criticizes his contemporaries for the introduction of different names for what seems to be the same disease, and conversely, for using the term fungus hematodes for which are obviously different diseases. He believed that an understanding and advancement of treatments for these diseases would not be possible if surgeons persisted in publishing reports of extraordinary cures, while ignoring all the other cases where similar treatments had no benefits. Basically, what this means is that the surgeons were publishing when a patient recovered, but they were not carrying out any clinical trials, such as we would do today, to test the efficacy of the treatments given. So the information published was anecdotal and really not of very much value. The patient underwent a series of treatment for his condition. At best, these were ineffective, and at worst they caused more suffering and injury to an already ill patient. However, the surgeons felt it necessary to attempt all published treatments. As was common at this time, he was prescribed treatment with a dozen leeches. Bloodletting was very popular in the 1800s as a means of balancing the four humours. This was a theory for the working of the human body, developed in ancient Greece and surviving until well into the 1800s. In this patient's case, they believed he had an excess of blood. This is clearly wrong, as he was pale and likely to be anemic. But the leeches were used to try and restore balance. Other treatments included administration of mercury, but this was found to be ineffective, and treatment was discontinued after 3 weeks. Iodine was also administered, even though the surgeons were doubtful if it would work, and it was discontinued as it made the patient extremely ill. Caustic alkali was taken orally in barley water for 3 weeks, and the surgeons reported that the patient felt better and was less pale, but the recovery was short-lived. Other treatments such as hemlock and arsenic were also used. These were common to relieve pain or to act as a stimulant, but they were equally ineffectual, and the patient grew weaker. The tumour also continued to increase in size. The surgeons decided to make an opening in it with a scalpel. It resulted in foul-smelling pus being released, and also hemorrhaging at the site occurring, which meant more blood loss. With our more advanced medical knowledge, we can see that bloodletting and all of these other treatments were having a damaging effect on the patient's condition, rather than helping to improve it. And the patient died in an emaciated state around 1 year after his initial complaint, and around 6 months after commencement of the various treatments. A postmortem was carried out at St George's by the surgeons Benjamin Brodie and Caesar Hawkins. It revealed a stomach tumour as shown in this lithograph on the right-hand side from an original 1827 publication. The tumour was described as having extensive adhesions to the abdominal wall, so this meant that it was growing outwards, away from the stomach. And it was also growing into the interior of the stomach, and it was ulcerated inside. The tumour was also found to have spread to the liver. On the left-hand side, you can see the preserved stomach of the patient that is still in the museum today. It would initially have been fixed in a formaldehyde solution to preserve it, and then it would have been transferred into a glycerol-based solution for long-term storage. The location of the esophagus is shown. That's the tube that leads from the mouth to the stomach to transfer food that you eat into the stomach. And you can also see the tumour towards the bottom, clearly visible in the body of the stomach. This is one of the oldest specimens in the St George's Museum collection. When I think about this patient, I wonder what his fate might have been today. Stomach cancers are generally diagnosed by a histopathologist by taking a small tumour sample and examining it under the microscope. In 1827, a pathologist at St George's investigated the cause of death in this way by examining tissue from the tumour using a microscope similar to the one shown here, and wrote a detailed description as follows. In all directions, numbers of small, round and oval cell bodies were seen, and also patches of columnar epithelium cells. Based on this description, the histopathologists at St George's today have told me that the patient's tumour was likely to be an adenocarcinoma. That's one of the most common stomach tumours. And would this patient have had a drastically different chance of survival today? Unfortunately, probably not, given the large size of the tumour when he first visited his doctor. An advanced adenocarcinoma remains a highly aggressive disease, but modern chemoradiotherapy combinations have improved the outlook for patients drastically, and now approximately 50% will have a 5-year survival, and that's unheard of until recent years. Thank you for listening. I hope you have enjoyed hearing about the museums and archives. If you'd like to keep in touch, you can catch up with us on Instagram at SGUL Museum Archives. Thank you.